I'd like to introduce my next speaker. We are going to be in the company of Mr. Rizwan Qureshi, who's a consultant cardiothoracic surgeon working in the NHS and in the private sector. He's on this WHO surgical checklist in cardiothoracic surgery, and that's going to be the topic of his discussion with a query, does it help? Thank you, Dr.
Thank you. Well, Assalamu alaikum. So good afternoon, everyone. Thank you, Shahid Latif, for such an introduction. I congratulate APS UK, particularly Dr. Sahil Chuptai, for organizing such a valuable meeting. And I welcome all the delegates who traveled from Pakistan, US, and other parts. Welcome on board here, sir. Thank you very much. You honored our conference, and welcome more and more. Well, this conference has been set up as a patient safety. And I think that is the basics of all the medical care. So I choose this topic because being a surgeon, the last 1 decade has seen a significant development in our morbidity and mortality because we address the basics. And I'll go through quickly with all the basics of it, how this evolved within my time, and then quickly snapshot of our experience. How does this go, sir? This way. Now, this was first of all, when public became aware and we started learning about our surgical care, that 234 million operations annually, globally, 11% of entire disease burden as a surgical help, 3 to 17% major complication, and within 1% death rate. That is the first time when we started becoming aware that this surgical care, where we are. Coming to my specialty, very complex surgical discipline because of a lot of physiology, perfusionist, a lot of other intensivist involvement. 12% adverse events and a rate of 17.4 per hour. I mean 11 per case. That was real eye-waking. And that was American Association when they came up with thoughts that this is why this is happening. And they found it's a non-technical skills, which are communication, cooperation, coordination, leadership, teamwork, which are all combined as called human factor in health. Human make errors, and 15% are preventable. This is what was. I think Professor Amir touched this Swiss cheese model, which is a standard model as in surgical disciplines, where we have to look into the basics, start from the management, all organization, management, then department, then your own practice, and then intraoperative. And that all combines, and that obviously, along with other surgical disciplines, applies to our surgical discipline as well, and that makes all the risk elements. So, basics first. When we look into odds of dying in air crash is 1 in 10 million. I think many speakers today touched this aviation safety. And odds of dying was 1 in 300. And that was the one. He was the key guy who made it all possible. These are one of the Wright brothers, we all know, they make the planes. 1900, he came up with a checklist with the takeoff, cruising, and landing. And they were applied, and significantly, all the air crashes, all the errors in aviation reduced. That was one of the model, and he used to always say that I learned that carelessness and overconfidence are usually far more dangerous, which had been in our practice. Carelessness and overconfidence. since from that area, 1999 was a key year when Americans Institute of Medicine, IOM, became aware, and then they reviewed. And my words, 50% medical errors by human factor, and the cost in billions of dollars and pounds. And since then, they made this is a landmark publication when they came up with. It's called "To Err is Human." This is a gold standard where they said this is a reporting system, that every error should be reported and it should be looked again and again, that why it happened. And then in 2001, there is another term came called never event. Never event means a significant event in your clinical practice. It should not never have happened. Before that, all the mistakes, everything is all hidden. It is all, we are all bosses, we are overconfident. And going through that, 2007 was the year when from Institute of Medicine, WHO came up with a surgical safety checklist. And on the basis of like aviation, sort of taking off, cruising, landing off, they call it sign in, time out, sign out. And what is that? When we sign in the patient, we always ask from the patient that who you are, what is your date of birth, what is the consent says, what site you are having operation, all the checklist we do in the presence of all the team. So that was like when you take off. So sign in. Then time out was before we give the incision, we make sure all the instruments are there, all the resuscitation trolley, all the equipments, they are all available, all the personnel are there, and all those details are there on those safety checklists. And obviously my colleague surgeons are fully aware of this practice. And then time out is before the patient leaves the theater. That is when you're landing. So it was launched in 2007. And then this WHO checklist was practiced in different parts of the world, in a diverse cultures, diverse communities, diverse number of patients. As my colleagues from Pakistan had been mentioning about limited resources, so they addressed those resources. They practice in Asia, New Zealand, US, as well as in Europe, and they found that significantly mortality and morbidity were reduced. And this was published in New Journal of Medicine. And the principles they came up with that, this is a deployable, this is supported by scientific evidence, this is evaluated in a multiple diverse setting, and ensures that it's got established safety principles, and it does not need big resources. And since then, 2007, and in 2010, NHS safety, we call it NPASA, National Patient Safety Agency, they adopted this. But one thing they added here in UK was they made it a 5 steps called briefing first, then sign in, time out, sign out, and then debrief. And what are those? Briefing is just a teamwork to improve outcome, where all the theater team, and in cardiothoracic we have perfusionists also, they're all there. You speak to them, you discuss, you plan, you make so it breaks all the communication barrier, introduces them to each other, creates a working environment, human factor, teamwork. And in debrief, you always, after the case has been transferred to ITU, you always discuss, all the team, that what was planned, what has actually happened, why did this happen, and what we should do next. We have a full role where we should write down the next day planning, next case planning. And then NHS came with this driver diagram where they said that if you have to reduce in perioperative care, two things: improve the teamwork and communication, and use evidence-based interventions like prophylactic antibiotics or VTE assessments. And then cardiothoracics took over, and Society of Cardiothoracic Surgeons and European Association of Cardiothoracic Surgeons, they adopted with changing some of those cardiothoracic basics, and they came up with this checklist, which guidelines published in the European Journal, Mr. Clark. And it has got all the recommendations, which we all know evidence is in class 1. It reduces morbidity, mortality. It has to have additional checklist as per specialty. And cardiothoracic surgeons should show strength and leadership. This is our experience which we did in Edinburgh. 3 years before the checklist and 3 years after the checklist. And if you notice, all the lists would show significant reduction in all the infective and also mortality was reduced. It's coming in publication in European Journal, I think next month. Safety culture is the national PASAs finally, and I think this is almost the most conclusive message. I'll go through quickly. You need a safety culture in healthcare to have all this patient quality of care. Knowledge, skills, and your attitude, those are the key pillars. Work them together and your performance would be good. Obviously, it takes time. You should modify for your local use, should be comprehensive, and educate your staff. They'll be more compliant. Create a team culture. In future, we should be accountable what we do. This is the most important thing. We should be accountable. We should not cut the grass. We should address the basics. Our patients are our top priority. And that is what patient safety is. This is about checklist that it takes only 2 minutes to perform. But we have noticed that results are after 18 months later. In concluding, like cardiothoracic surgery related, that it's a high-risk endeavor, but it needs a culture of safety. Checklists should be applied on every cases. And if you have to see the impact of safety measures, please create a culture, a team culture. And always, always, patient safety should come first. Many thanks.